The term diabetes mellitus describes diseases of abnormal carbohydrate metabolism, which is characterized by hyperglycemia, the elevated blood glucose level. The uncontrolled diabetes is the leading causes of cardiovascular disease and kidney disease and nerve damage. Normally, when we eat our food, such as carbohydrate rich food, our body breaks this down and absorbs it in circulation as glucose, which is a type of sugar. This increased blood glucose level in our body will stimulate the pancreas to produce insulin secretion from the beta cells of our pancreas. This insulin will promote glucose storage in tissues by binding onto the insulin receptors on the surface of the cells around our body. This leads to decreased blood glucose level. Diabetes occurs when there is a problem with insulin secretion or peripheral resistance to the action of insulin. This problem leads to hyperglycemia and its associated complications such as cardiovascular disease, chronic kidney disease, and neuropathy. Diabetes is mainly divided into two types: type 1 diabetes mellitus and type 2 diabetes mellitus. Type 1 diabetes mellitus. It is characterized by autoimmune destruction of the pancreatic beta cells, leading to absolute insulin deficiency. No insulin production leads to increased glucose level in our body. Because of absence of insulin, patients with type 1 diabetes mellitus should receive exogenous insulin lifelong. So, it is also called as insulin dependent diabetes mellitus. The causes for this type 1 diabetes mellitus may be autoimmune disease or genetic predisposition or environmental. In environmental, viruses like Coxsackie B virus or mumps. The most common cause of type 1 diabetes mellitus is autoimmune. This type 1 diabetes mellitus usually diagnosed in childhood, so it is also called as juvenile diabetes mellitus. But in some cases, it may take up to 30 years to diagnose type 1 diabetes mellitus. A person with type 1 diabetes mellitus often presents with diabetic ketoacidosis, which is an medical emergency. Type 2 diabetes mellitus. Most common type of diabetes mellitus in adults, and it is characterized by hyperglycemia caused by combination of insulin resistance and defective insulin secretion. The causes for this insulin resistance may be environmental, related to overeating or sedentary lifestyle or overweight, such as obesity. But however, uncontrolled diabetes mellitus may lead to another acute problem called hyperglycemic hyperosmolar syndrome. Other types of diabetes mellitus are gestational diabetes mellitus and latent autoimmune diabetes of adults. In gestational diabetes mellitus, hyperglycemia develops during pregnancy because of the secretion of placental hormones which causes insulin resistance. LADA, which means latent autoimmune diabetes of adults. It is a subtype of diabetes in which the progression of autoimmune beta cell destruction in the pancreas is slower than the type 1 and type 2 diabetes mellitus. Patients with this type of diabetes are not insulin dependent in the initial 6 months of this disease onset. Clinical manifestation. Classical symptoms of diabetes mellitus are polyuria, polydipsia, and unintentional weight loss. Polyuria, which means increased urine output. Normal urine output is 0.5 ml per kg per hour. In polyuria, patient may urinate greater than 2 ml per kg per hour or greater than 3 liter per day. Polydipsia, which means increased thirst, or patient will drink more water than usual. The patient with diabetes mellitus will drink greater than 6 liters per day. And unintentional weight loss. These three are the classical symptoms of diabetes mellitus. Here I want to share some important MCQ points. That is, polyphagia is not a classical symptom of diabetes mellitus. Remember it, polyphagia is not a classical symptom of diabetes mellitus. Other symptoms of diabetes mellitus. fatigue, weakness, vision changes, tingling or numbness in the hands or feet, and dry skin. How to diagnose diabetes mellitus? For diagnosing diabetes mellitus, we have some tests. First, we see about glucose tolerance test. In glucose tolerance test, we have to measure blood glucose level in two stages. First one is fasting stage and another one is postprandial stage. For fasting, patient must be refrained from food for greater than 8 hours. In postprandial, ask the patient to take 75 gram of glucose and assess blood glucose level after 2 hours. In fasting stage, if the patient's glucose level is less than 100 means it is normal. If the glucose level is in between 100 to 125 means then the patient is in pre-diabetes stage, which means impaired fasting glucose. If the patient's glucose level is greater than 126 means the patient is in diabetes mellitus or patient having diabetes mellitus. For postprandial, if the patient's blood glucose level is less than 140 means it's normal. If the glucose level is in between 140 to 199 means patient is in pre-diabetes stage, which means impaired glucose tolerance. If the patient's blood glucose level is greater than 200 means then patient having diabetes mellitus. Postprandial glucose level is not used for diagnosis. Instead, it is used for follow-up and monitoring in patients with diabetes mellitus. Random blood sugar. It is also used for diagnosis if patients have the classical symptoms of diabetes mellitus such as polyuria, polydipsia, and unintentional weight loss. HbA1c assay. It is used to assess past 3 months of blood glucose level. It is usually expressed in percentage. The normal level of HbA1c is less than 5 to 6 percentage. In pre-diabetes, it is in between 5.7 to 6.4 percentage. In diabetes patient, it is greater than 6.5 percentage. According to American Diabetic Association, for diagnosing diabetes mellitus, one of the following criteria should be present. One is classical symptoms plus RBS greater than 200 mg per deciliter, and another one is asymptomatic client with fasting blood glucose level greater than 120 plus 2 hours postprandial blood glucose level greater than 200, and another one is asymptomatic client with HbA1c greater than 6.5 percentage. Complications, which is divided into two subtopics, acute and chronic. In acute complications, we have hypoglycemia, diabetic ketoacidosis, and hyperglycemic hyperosmolar syndrome in type 2 diabetes mellitus. Chronic complications, which is divided into microvascular diseases and macrovascular diseases. In microvascular disease, we have diabetic nephropathy, diabetic neuropathy, and diabetic retinopathy. In diabetic retinopathy, the patient may come to the hospital with sunflower cataract or sudden blindness. In diabetic nephropathy, the patient may have microalbuminuria. The golden standard test to screening for diabetic nephropathy is 24-hour urine albumin monitoring. And diabetic neuropathy, the patient may experience tingling or numbness in his hand or feet, and patient can't able to perceive pain because of impaired nerve transmission. In macrovascular disease, the patient may have coronary artery disease or silent MI and peripheral arterial disease. Due to narrowing of the tibial artery, the blood supply to the leg is cutted. So the patient may experience gangrene, the blackening of the toes. The most common cause of death in diabetes patient is silent MI because the patient can't able to perceive pain due to diabetic neuropathy. In acute complication, we see about hypoglycemia. It means less sugar level in our blood. Blood glucose level is less than 70 milligram per deciliter. Severe hypoglycemia occurs when blood glucose level goes beyond less than 40 milligram per deciliter. This hypoglycemia occurs when there is too much of insulin or oral hypoglycemic agents or too little food or excessive physical activity. Clinical manifestation of the hypoglycemia. The patient may present with sweating, tremor, tachycardia, and palpitation, or even the patient may also having hunger, severe hunger. For managing hypoglycemia, we have rule of 15. According to this rule, you have to give 15 gram of simple carbohydrate such as juices like that. After 15 minutes, you have to check blood glucose level. If the blood glucose level is greater than 70 means you no need to do anything. If the blood glucose level is less than 70 milligram per deciliter means you have to repeat the step. Next, diabetic ketoacidosis. It is caused by absence of insulin in our body. This absence of insulin can lead to gluconeogenesis, which means the production and release of glucose from non-carbohydrate sources such as fat and protein. The end product of this fat and protein is ketone bodies. These ketone bodies will accumulate in our blood. This leads to acetone breath and Cushman breathing. And another side, the lack of insulin will increase the production of glucose in our liver. This leads to hyperglycemia. This hyperglycemia can lead to polyuria. This leads to dehydration in the patient. This dehydration patient may come with weakness and headache and increased thirst. The classical symptoms of diabetic ketoacidosis is hyperglycemia, dehydration, and electrolyte loss, and acidosis. This may manifest as Cushman's breathing. And other symptoms are fatigue, blurred vision, weakness, headache, and orthostatic hypotension. Management of diabetic ketoacidosis. For management, first we have to do rehydration. Rehydration important for tissue perfusion. In addition to tissue perfusion, the fluid replacement will enhance the excretion of glucose by the kidney. And second step, we have to correct electrolyte loss. And third, we have to correct acidosis. And fourth, we have to correct hyperglycemia by insulin trip. For rehydration, initially we have to use 0.9% NS, usually at the rate of zero point 0.1 to 1 liter per hour for first 2 to 3 hours. In restoring electrolytes, the major electrolyte of concern is potassium. Because a patient's serum potassium level may drop quickly as a result of rehydration and insulin treatment, potassium replacement must begin once the potassium levels drop to the normal in the patients with diabetic ketoacidosis. Reversing acidosis and treating hyperglycemia. Ketone bodies accumulate as a result of fat breakdown. Administering insulin will help in inhibiting fat breakdown and decreasing blood glucose level. Insulin is usually infused IV as a slow and continuous rate. Example 5 units per hour. When blood glucose level reaches 250 to 300 milligram per deciliter, change the IV fluid NS into D5NS or D5 45% of NS. Regular insulin is the only type of insulin which is approved for IV use. Important for nurses, while hanging the insulin chip, the nurse must flush the insulin solution thoroughly, the entire infusion set, and discard the first 50 ml of fluid because insulin may adhere to the inner surface of the plastic IV infusion set. Therefore, the initial fluid may contain lower concentration of insulin. Hyperglycemic hyperosmolar syndrome. It is a metabolic disorder of type 2 diabetes mellitus, which is caused by a relative deficiency of insulin. Clinical manifestations are hypotension, profound dehydration, poor skin turgor. For assessing and diagnosis, we have to assess blood glucose level. In this metabolic disorder, the blood glucose level is range between 600 to 1200 milligram per deciliter. Other than blood glucose level, all other parameters like pH and bicarbonate level, electrolyte, and renal parameters are within the normal range. Management. For managing HHS, we have to administer fluid with insulin. The difference between diabetic ketoacidosis and hyperglycemic hyperosmolar state. The diabetic ketoacidosis is most commonly associated with type 1 diabetes mellitus, whereas hyperglycemic hyperosmolar state is most commonly associated with type 2 diabetes mellitus. The onset of diabetic ketoacidosis is rapid, whereas hyperglycemic hyperosmolar state is gradual. The blood glucose level is within 300 to 500 in diabetic ketoacidosis, whereas in HHS, the glucose level may be greater than 800. Serum ketone bodies are present in diabetic ketoacidosis, whereas in hyperglycemic hyperosmolar syndrome, the serum ketone bodies level are within normal. Serum osmolarity is 300 to 320 in diabetic ketoacidosis. In hyperglycemic hyperosmolar state, the serum osmolarity is 330 to 440. And diagnostic criteria for diabetic ketoacidosis are elevated blood glucose and anion gap acidosis and serum ketone bodies. Whereas in hyperglycemic hyperosmolar state, elevated blood glucose and elevated serum osmolarity and mental changes. Let's summarize diabetes mellitus. Diabetes mellitus, it is an abnormal carbohydrate metabolism which is characterized by hyperglycemia. Classification of diabetes mellitus. Two main classification, type 1 and type 2. Type 1, which is due to autoimmune destruction of pancreatic beta cell. Type 2, which is due to insulin resistance. And classical symptoms of diabetes mellitus: polyuria, polydipsia, and unintentional weight loss. To diagnosing diabetes mellitus, glucose tolerance test, random blood sugar, and HbA1c assay. Complications of diabetes mellitus: acute and chronic. In acute, hypoglycemia, diabetic ketoacidosis, and hyperosmolar hyperglycemic syndrome. In chronic, microvascular and macrovascular, diabetic neuropathy, diabetic nephropathy, and diabetic retinopathy. In macrovascular, coronary artery disease or silent MI. That's all for today. If you like this video, subscribe to our channel and share it with your friends. Thank you for watching.